All right, well, I think we'll get started with introductions. Welcome again, everybody. Dr. Kim here from Suncloud Health. I'm the Chief Medical Officer here, and we are delighted to host these CEU and CME series. Um, know that the presentation today will be available on our website, enduring for a year. So not only for you to refer to the slide deck and the references contained therein, but also send it out to colleagues who you think may be interested or who may benefit from hearing what Dr. Yager has to say today. I'll tell you a little bit about Suncloud Health. We are a residential PHP and IOP treatment center serving adults and adolescents in separate programs. We're based in the Chicago area. We have two residential units. One is a specialty eating disorders and addiction co-occurring unit, and one is a unit that serves people with general mental health concerns, eating disorders, and/or addictive disorders. And I would say all of our patients have some way, shape, or form of trauma as well. So I'm delighted today to be able to introduce you all to Dr. Joel Yager. I'm going to read the brief version of Dr. Yager's bio, and I'm just incredibly grateful to be able to have Dr. Yager here today. As we were talking before we started, Dr. Yager has been one of those giants in the field whose work I've followed really since my residency training back in the late 90s. And what a gift to be able to have you here today and to present on this particular topic. So Dr. Yager is Professor Emeritus of Psychiatry at the University of Colorado and also Professor Emeritus at both UCLA and the University of New Mexico. He is a graduate of CCNY, received his MD from Albert Einstein College of Medicine in New York City, and completed an internship in internal medicine and general psychiatry residency at its affiliated medical centers. He served as a major in the U.S. Army at Fort Ord, California. He's active in the American Psychiatric Association. He has chaired the APA's Steering Committee for Practice Guidelines, the Council on Medical Education and Career Development, and the Council of Quality Care, and also served on several DSM-5 review groups. He chaired the APA work group producing practice guidelines for the treatment of patients with eating disorders through 3 editions, and subsequently served as a consultant and member of the systematic review group for practice guidelines. Over the years, he's served as the president of the American Association of Directors of Residency Training, the president of the Academy for Eating Disorders, and on several NIMH, AHRQ, and Institute of Medicine committees. He's also the past chair of the Clinical and Scientific Council of the National Eating Disorders Association. Dr. Yager is the Eating Disorders section editor for UpToDate. He has served on the editorial boards of the American Journal of Psychiatry, Archives of General Psychiatry, Academic Psychiatry, International Journal of Eating Disorders, the Journal of Eating Disorders, and several other editorial boards. For 25 years, he was an associate editor of the New England Journal of Medicine's Journal Watch for Psychiatry, and for 24 years, he served as an editor-in-chief of Eating Disorders Review. He's published nearly 400 peer-reviewed articles and chapters and edited 8 books. His research and scholarship have focused on professional development and medical education, eating disorders, primary care, and consult liaison psychiatry, practice guidelines, mental health services research, and other aspects of general psychiatry. In support of his efforts over the years, he's received grant funding from the NIMH and several foundations. For his professional contributions, he has been honored by the American Medical Association, American Psychiatric Association, Association for Academic Psychiatry, and the American Association of Technology in Psychiatry, the Academy for Eating Disorders, and the National Eating Disorders Association. So without further ado, I will turn it over to you, Dr. Yager, and we'll probably wrap up the didactic the slide portion around noon, a little bit after noon, and then we'll have ample time for discussion. Any questions about CEs or CMEs? One of my colleagues here is going to put Tammy Gazer's email address in the chat. Expect an email from her later today for instructions on obtaining your CE or CME certificate.
Kim, thank you so much for that wonderful introduction. So these are my disclosures for today. I'm very unconflicted, so I don't have a lot of conflicts of interest. I'm a section editor for Up to Date, which I hope many of you look at. It's a terrific online medical encyclopedia, and we have about 24 chapters devoted to eating disorders. Next, please. And what we're trying to do today is get you to understand the notions of what we're calling foreseeably hastened death or slow suicide in patients with psychiatric disorders. And this is very prominent in people with eating disorders, alcohol use disorder, other addictive disorders, and borderline personality disorders, people who have lost hope, who are sort of wrapped up and addicted to something that they just can't shake, and who slowly slide down the hill toward death. We'll also talk about what constitutes a good death, the death that you might want for yourself, or for your family, and hopefully for everyone else, and then look at the odds of having a good death if you're somebody with a psychiatric disorder. And finally, we're going to look at the issue of palliative care, how it interfaces with psychiatry, and how patients with psychiatric disorders may be able to benefit from from palliative care, and how you as practitioners might be able to access it and know what it's about and feel comfortable with it. Next, please. So the question is, how did I get into this? Well, the first thing is I'm old. I don't feel old, I don't act old, I don't look old, but I'm 83, so I guess that counts as something. So I'm older than most people on average before they die. And over the last few years, I've dealt with a cancer. I have a long history of being interested in people who died in the history of psychiatry, and wrote a little article in JAMA called "And Then He Died," which generated a lot of interest. And I've long been interested in psychic pain and suffering in patients with psychiatric disorders, how we appreciate suffering, how we contend with suffering, how we deal with it. Also, I've been looking a lot at severe and enduring anorexia nervosa, and a couple of years ago co-authored an article on terminal anorexia nervosa that stirred up a lot of controversy, and a lot of people in the field hated the idea that we should even think about there being a terminal phase of anorexia nervosa. But over the decades of my own practice, I've had half a dozen patients who have died from anorexia nervosa under my watch and during my care. And there was no question in my mind that they at some point had what you would call a terminal condition. And many other clinicians who've worked very closely with people with severe and enduring anorexia nervosa will describe the same thing, that they've had patients who have failed every conventional treatment and who have really then turned around and said, I'm ready to give it up, and have died. As a result of this work, I've collaborated with general internists who've been palliative care specialists and learned about palliative care, hospice care, and how it may be of benefit to people with anorexia nervosa. I've had several of my own patients in palliative care and hospice care programs. They've all really benefited from these programs. And now Colorado turns out to be a state where medical aid in dying is permitted, one of 10 states plus the District of Columbia. And I know that Illinois may be thinking about it now. And the question then comes, would patients with chronic, enduring, severe, miserable psychiatric disorders ever qualify for medical aid in dying? There's an experiment that will begin in Canada in 2027, and this has been going on in Europe now for about 20 years or so, where some patients with psychiatric disorders can ask for medical aid in dying. So we may get into that in the discussion section. Next. So we're going to be talking about natural versus unnatural deaths, or medical and somatic versus external causes of death in patients with psychiatric disorders, the difference of dying with a psychiatric disorder from dying from a psychiatric disorder, where the psychiatric disorder is much more central to the death events, and then the notion of what is death with dignity that we all aspire to versus death with indignity, which many of our psychiatric patients currently have, dying by suicide, dying on the streets, dying in homeless shelters, and things of that sort. So we'll cover this as the general territory. I'm going to have a lot of slides with a lot of data. I will not read the data. I'm going to talk around the data so you get the general idea, and you can go to the website and look at the slides and look at the references if you're so inclined to get into the weeds, because depending on the patient that you're taking care of, the weeds may matter. So let's go to the next slide. And this looks at natural causes of death versus unnatural causes of death. So natural causes of death are all of the medical causes that you're very well acquainted with, and unnatural causes include suicide, accidents, assaults, and substance-induced deaths, which can be very direct or indirect, and then non-suicide drug-induced deaths that are just kind of accidental, parasuicidal deaths that go wrong, and any other kinds of weird causes of death. So it turns out, next slide, that if you look at people worldwide, almost 15% of the deaths are attributable to mental disorders. That's a huge number of people in the world. And among those with mental disorders, roughly 2/3 will die of natural causes, heart attacks, stroke, lung disease, although a lot of those have to do with tobacco addiction, have to do with alcohol addiction, other things that will be contributing even to severe obesity that may have some iatrogenic contributions in terms of people getting second-generation antipsychotics, putting on a lot of weight, and developing cardiovascular diseases and hypertension. So a lot of these things are subtle in their background. But so about 2/3 of people will have these natural deaths. About a third, maybe less than that, 20% will have unnatural deaths due to suicide, accidents, and so forth. And it turns out, if you look at this way of separating out natural versus unnatural causes of death, that people with a psychiatric disorder, a severe mental illness, generally live 10 years less than the people in the community. So you're losing about 10 years. We'll get into more details because some diagnoses carry much worse prognosis than that. One of the things that I've been really surprised at over the years is trying to do follow-ups of my own patients from time to time. And now there are patients that I've seen in my own practices from 40 to 50 years, and I look them up a few years later and they're dead. They died in their 50s and their 60s and so forth. When I was a very young psychiatrist, one of my first academic jobs was to put together the consultation service in the brand new VA hospital on the campus of UC San Diego. So I was on the UC San Diego faculty from 71 to 73. And I put together a liaison service and we did consultations. And I wanted to do a 6-month follow-up of patients on whom we consulted. It turned out 50% of the patients we had seen in consultation were dead. They had died. Many of them died of hospital-related diseases, of delirium, of strokes, of heart attacks. But the fact is, a lot of people with psychiatric disorders have early deaths. Next, please. If you look at a little bit of the detail, standardized mortality rates means you can compare a cohort of people with psychiatric disorders compared without. And if you take any age range, particularly if you're getting up into the 50s and 60s, people with psychiatric disorders have 3.5 times the standard mortality rate compared to the general population. And notably, again, they're dying of chronic lung disease, lung cancer, cardiovascular diseases, and flu. And among the unnatural deaths, accidental deaths are twice as frequent as suicide. So people suicide, but they also have accidental deaths. What does that mean? They're lousy drivers. They don't think about things. They walk off the cliff. They put themselves into risk-taking situations where they're more likely to have accidents. They don't care about themselves as much. They're not as cautious. So again, among unnatural deaths, only 1/3 of them are due to suicide, and the others are due to accidental causes or getting shot. So they're in situations that may be domestic violence, or there may be situations that may be dangerous neighborhoods, all of those kinds of things. Next, please. With patients specifically with schizophrenia or bipolar disorder, there may be 10 to 20 years shorter lifespan. So if the average American lifespan is age 78, roughly, you're looking at people who are going to be dying between 58 and 78, 58 and 68. A lot more people with psychiatric disorders are dying there. And alcohol disorders, even more so, maybe 25 years off your life. And with anorexia nervosa, it's off the charts in terms of the number, the suicide rate, particularly for people who have co-occurring alcohol use disorder and anorexia nervosa. The rates in a study done at Mass General are 50 times the rate of suicide in the general population. And so people with anorexia nervosa die young, they die of medical causes, and if they're co-occurringly addicted, they'll die of suicide in very, very high rates. Next, please. So why do people with psychiatric disorders die so young? Well, the first thing is that they get less medical care, general medical care. They're less likely to be screened with mammography, colonoscopy, and all of the things that most people go to their PCPs for to do early detection and intervention. They are less likely to get routine care. They're less likely to go to a PCP to just get checked up. And once they have symptoms, they are tardier about going to get them treated. Some of them ignore them longer. They don't care about them. They don't care about what happens to themselves. So they delay in seeking symptoms. And they have higher rates of smoking, obesity, and again, some of that is due to medication. They have less access to care, even if they wanted care. And once they're in care, there are studies to show that people with serious mental disorders receive less aggressive medical treatment. So all of these things add up to contribute to why people with mental disorders, psychiatric disorders, are likely to die younger. Next, please. Another way of slicing the population, besides natural versus unnatural, is medical causes versus external causes. These are just ways that demographers and epidemiologists play with data. The difference between medical and external and natural and unnatural is that in this way of looking at things, the alcohol-related deaths are included in these medical things and not in the external. Basically, the findings are very similar. We'll go to the next slide. And this is a study of 250,000 Scandinavian patients who were looked at versus in this paradigm of medical versus external. And in this group, life expectancy of people with a serious mental disorder was 15 years shorter for women, 20 years shorter life expectancy for men. And the mortalities were dependent on your diagnoses, and they went from 3 times as frequent to 77 times as frequent, depending on your specific diagnosis. The mortality with medical conditions were highest for substance abuse and people with personality disorders. The mortality for suicide were highest with people with mood disorders and personality disorders. And substance abuse across the board, if you had a comorbid substance abuse, increased your mortality rate at every range for every comorbid psychiatric disorder. Next, please. So again, if you had bipolar disorder, you had 6 times the death rate for external causes compared to people without a psychiatric disorder. And among somatic disorders, alcohol-related causes contributed more to excess mortality than even heart disease in Scandinavia. A hell of a lot of alcohol use, and anybody drinking as much as they did was at risk for having a shorter life. Next, please. So with any cause of death, medical or external, what you have to ask is, does this diagnosis really explain death? Or was it necessary and sufficient, or did other things have to come in? So if somebody said to die of lung cancer, did they really die because in the background was a very heavy smoking history? If they died of liver disease, in the background was there a very heavy alcohol history? So the question is, did people die with or die from their disorders? In the COVID epidemic, people were said to die from COVID if they had a very bad infection and their lungs stopped working. They were said to die with COVID if they came into the hospital, had a medical diagnosis, and incidentally had COVID at the same time. So the COVID may have weakened their immune system and contributed, but they died of a stroke or a heart attack or something like that. In psychiatric disorders, you die from a psychiatric disorder if it's clear that you died from suicide or a drug overdose or an alcohol intoxication. But most people in the medical examiner's office would say that a patient who came in with a stroke or a heart attack or lung disease, who also had bipolar disorder or who also had anorexia nervosa or who also had alcoholism, died from their medical disease with a psychiatric disorder. It's a distinction, but it's an important distinction when you say what really caused this death. And when you dig into the weeds, you realize that things that people with psychiatric disorders are more likely to suffer from really contributed in a substantial way to what are seemingly earlier medical illnesses. Next, please. So now I'm going to get personal. You think about this. How would you like to die? I'm giving you a minute to reflect on that. Would you like to die in your sleep? Would you like to die suddenly? Would you like to die knowing you were going to die in bed over a couple of days or a couple of weeks so that your family could come around and sing songs to you and be nice to you and have a going away party, basically? How would you like to die? And what impact would the way you die have on your loved ones and your family and your kids and your neighbors? So you don't want to have conscious awareness of death or just have it hit you like a bus or getting struck by lightning. Next, please. Then turn it around, mentalize. How would you like the person closest to you to die? Do you want it to be sudden and then you get a phone call and you say, your husband or your wife just died and we found them in the street or in their office or in the chair or they were hit by a car or a car accident? How would that impact you? Or would you prefer if they had an illness that was going to lead them to die in a month or 2 months, and you had the agony of waiting and dealing with that, but you knew that you were going to be able to say goodbye in a nice way? So, and how would that kind of death impact you and those closest to you? Everybody's going to have this at some point. Your parents are going to die or have died. Your partner or spouse is going to die or have died. Your kids are going to die, hopefully not before you do, because that's one of the worst things in the world is to have your kids predecease you in terms of life events and life stressors. That's awful, but it happens to a heck of a lot of people. So we're all going to face this. How would you like to do that? And then think about your patients. Do they have the right to think about the same questions? Do they care about how they die? How will it affect them? How will it affect their families and so forth? Next, please. So what is a good death? One of my own colleagues at UCLA, whose name was Ed Schneidman, who was a professor of thanatology. He was the first professor of death studies, characterized a good death in this way. You're free from pain, you're lying in your own bed, you're at home, everybody you love is around you, they're telling you what a great person you are, how much they're going to miss you, how much they got from you, what your legacy is, they're going to play nice music, they're going to put flowers around your bed, and you look back on your life and you say, you know, it was a pretty good trip. I did a nice job, I helped people, I'm proud of myself, I left my family in good stead. I took care of my funeral arrangements. I have insurance. The kids know where my will is. Everything is in order. That is a good death. Now, how many people die a good death? Fewer than would want to. Next, please. That's what we aspire to. But most people don't have that kind of a death. Some do. I've had relatives who've been blessed and have had that kind of death. My parents both died suddenly. They had no time for that kind of a death, and we had no time to prepare for it. One of my in-laws died this way with a good death. The other one died suddenly. So people are going to die as they will. It's out of our hands. But there's a spectrum, so having this kind of a good death is probably the ultimate in death with dignity. And then there's a spectrum of death with dignity, some dignity, to death with indignity. And indignity, again, as I said before, is dying of shame, dying where you go into hide someplace, where you kill yourself and don't tell anybody about it, where you die in the street because you're bleeding out from an esophageal varices and cirrhosis, where you're dying of a heroin overdose someplace, where you're dying of fentanyl someplace and nobody expected it. So that's death with indignity, and where your parents won't even write in the obituary what you died from because they're ashamed of it. Next, please. So where do people actually die? And this data comes from Medicare, so it has to do generally with people who are on Medicare who are older or who are disabled. And you can see it's all over it. Home, hospitals, nursing homes, fewer than 10% in a hospice. But among Medicare recipients, increasing numbers are getting hospice care. Could be at home, not necessarily in a hospital-based hospice or in a physical hospice. And for those of you who watch John Oliver, you know that there are a lot of scams in the hospice business, that the hospice has become a way to make money, and people who are, excuse me, saying that they're giving hospice services are often cutting corners and not giving such good care. So even if you're going to try to access hospice, you have to be very careful about making sure that you have a qualified provider. Next, please. So what do you want to think about as a provider and as someone who's going to die in terms of qualities that would go into the end-of-life care that you experience, receive, or deliver? So the first thing is symptom control. You hope that the patients you're caring for, or you yourself, will not be miserable and suffering from pain or from some psychological horror. So you want to get rid of psychological or physical suffering. You want to be prepared for it. So you want to think about, what is death about? What does it mean? What do I expect? Do I have faith? And do I believe in heaven and hell? Am I going to actually go to the pearly gates? Am I going to meet God? Am I going to meet Jesus? Am I going to meet Mohammed? Who am I going to meet? Anybody. Will I be reincarnated? Does my soul have any existence after I die? Or am I just going to wind up with recycled atoms and I will have lived a good life, and whatever I am dies when my nervous system dies, because that's my experience of life, is all recorded there. But guess what? My hard drive just disintegrated. So how do you think about those things? Do you feel connected with anybody when you're going to die, or is it absolutely a lonely trip? Can you say goodbye to your kids and to your partner or to your loved ones and best friends when you die? The transcendence is what I talked about before, is your belief in some spiritual surrounding of death. To what extent is what you want when you die and what your family would like for you listened to and respected? If you wrote a DNR because you don't want active medical care, you don't want heroics, and the medical staff ignores your DNR and tries to jump on you and give you CPR and do all of these things, and you die in pain with cracked ribs in a hospital on a hospital floor, is that what you want? Or do you want them to actually listen to the fact that you said, let me just die peacefully? How satisfied will your family be with how you die? And how much strain have you put on your family and on your caregivers in the process of your dying? Have you made it easy for them, or have you made it hard for them? So all of those things go into considering quality of the end of your life. Next, please. So what happens if you have a psychiatric disorder? It turns out, not surprisingly, that people with serious mental illnesses are less likely to receive good quality of care at the end of their life. They're more likely to die in sort of nursing homes where they're ignored or not attended to in meaningful ways. Those with medical comorbidities are more likely to die in a hospital. Those dying of suicide are more likely to die in their own homes by themselves, nobody around them. Or maybe if they really hate their family, they'll go into a room and suicide and let the family find them in an hour or two, as almost like a last sadistic act of some kind. And we know that they are less likely to get good care. For example, in the last 6 months of life, people with schizophrenia and medical diseases are less likely to get good pain control. Those studies have been done. The references are there. Next, please. And studies in the US, Canada, Australia, New Zealand all show that people with psychiatric disorders are less likely to utilize palliative care or hospice care at the end of life. So they are just more on their own, more without these kinds of caring professionals contributing to their well-being. Next, please. In France has set up a system where people with psychiatric disorders actually get more hospice care. But what they do in France is people are less likely to get decent medical care when others would still be getting medical care. So they're jumping on people early, but they're giving them less medical care, but they are trying to attend to their psychosocial needs. And this is generally seen more in social democratic countries in Western Europe that have, universal health care. Then this would be seen in the United States or other countries that depend on insurance-based care and where there are a lot of uninsured people. Next, please. So again, what provides patients with psychiatric disorders from having good deaths? And first is that they have less access to care. They're less likely to live in a decent place. Many of them are living in nursing homes, psychiatric hospitals, single-room occupancies, domiciles of one kind or another, or on the street. Who's going to be around when people with psychiatric disorders die? Well, if they're alienated from their families because they've been yelling or screaming, or the families are embarrassed and ashamed by them, they're not going to have loving, caring family members around. Or if they do, they still may be fighting their battles to the very end. There may be disgruntled family members. There may be blaming family members. There may be shaming family members who say, you only did this to yourself. If you only had stopped drinking 10 years ago, you wouldn't be dying right now and causing me all this grief. And all of those kinds of family battles that can go right into the death room. And the last couple of hours or minutes of a dying person's life can still be filled with bile and regret and blaming and misery and fighting and stuff like that, conflicts. Will people who are dying have medical staff who really know them around, doctors and nurses and therapists who've had long-term connections with them? Or will those people have abandoned them when it looks like the game is over and I can't do anything more for you as a living person, so I'm not going to keep paying any attention to you, even though I know you're dying now? So is there more abandonment like that? What's the patient's mental state like in the process of dying? Are they clear-headed and know what's going on? Or are they demented, delirious, delusional, and ignoring it? So all of those things will get in the way of having this good, dignified death. Next, please. Now, it says physicians, but I'm sure that the same issues apply to all caregivers. So we as caregivers differ in our ability to be with dying people and how we react to them and how comfortable we are with them. So some physicians are dedicated to just expanding life, and they're not going to stand for the idea that you're dying, and they'll do whatever they can to continue your life, even if it's a waste of money and a waste of time. We know that. Maybe a third of physicians will just be gung-ho and keep going, keep fighting death as if death was an enemy here. And they have an aversion to the fact that people die. 100 years ago, doctors knew that their patients were going to die, and they would sit at the bedside and be participating in the death vigil. Current doctors are much less likely to spend time doing that. Hospice nurses are, some physicians are, but a lot of caregivers get hands off at death. A lot of caretakers are uncomfortable talking about death. Like, do you know what's going on? Do you know that you may die? What would you like? That's a hard conversation for people who are inexperienced or untrained in that. Some people want to avoid conflict, and they don't want to bring up unpleasantries with people, even though it means that they're not going to talk about the fact that you're going to die in a week or in a month or in a year if you keep doing what you're doing. That this is a death trajectory you're on right now. Some people are cockeyed optimists and just believe we can take care of this people. In the eating disorder field, I've really found that to be the case, that there are practitioners in eating disorders who don't realize that there are genuine limits to what we can do for people who have severe and enduring anorexia nervosa with comorbidities, bad OCD, bad borderline personality disorders, and substance abuse. And we can shoot our load, and they're still not going to get better. And we can do it over and over and over again and keep giving them what are ineffective treatments while they, knowing they're ineffective, may either go along with them and say, stop kidding me or stop torturing me. So we have to look into our own hearts as caregivers in terms of where we stand with all of this. And there's money. Money is at the bottom of this. Are we going to make money by taking care of this person? Is there any money to be made by taking care of them at the end of life? Well, hospice providers have found a way to make money about that. But is my company going to make money, or are they going to tell me to stop wasting my time? So these are issues to be considered. Next, please. So staffs are challenged by taking care of patients who deny that they're dying or delusional, demented. Is hard. How do you give good care to somebody who denies that there's a problem, who wants to get up and do everything and so forth? And then the question is, to what extent can you still respect these patients and treat them in a sympathetic way, alleviating suffering and misery in the process of their dying? Those are really hard things to do. Next, please. So now the question is, are there people with end-stage psychiatric disorders? And my colleagues and I have published this. You'll be able to read about it in Psychiatric Times in September, or in the Journal of Nervous and Mental Diseases, still in press, about to come out. Irrespective of whether somebody is delusional or not, their behaviors will let you know whether they're on a death trajectory. And the behaviors are: they avoid treatment, they refuse treatment, they fight treatment, they don't want to know from treatment, and they keep doing what they're doing that's self-harming. So this could be, I'm shooting up. This could be, I'm drinking a fifth a day. This could be, I'm not eating. This could be, I'm exercising 12 hours a day. This could be, I am cutting myself repeatedly deeper and deeper to get the same effect. This is, I am playing Russian roulette with something or other. And just, you can tell it's happening. Next slide. Years of treatment have been intolerable or ineffective, and they say, the hell with you, and they have washed their hands of the care system, and they keep doing what they're doing. Next. Keep putting themselves in risky situations, in domestic violence situations, keep going back to abusers whose behavior is getting escalated and escalated, and they're challenging and defying these abusers or triggering them repeatedly. And again, they're restricting food or fluid or escalating the use of toxic substances or driving when they shouldn't be driving, and all of these kind of things that are preventable, but they're on a collision course with death, and there's very little you can do medically or even legally to stop them. We can't put somebody who's a chronic alcohol abuser on a lifelong involuntary hold. We try to do it, it lasts for 32 hours, 2 weeks, who knows how long. Same thing with a severe anorexia nervosa patient who said, I don't want to be treated. There's just so much you can do with involuntary commitment or treating somebody against their will. It doesn't work at a certain point. So what do you do then? Do you say, I don't want to have anything more to do with you? Or do you say, let me help you still get as much dignity and relief and pain of suffering as you can? Next, please. And this is what goes into slow suicide. So there are patients with what have been called the fuck-its, who say, I don't care about what happens to me. I'm just going to keep drinking. I'm just going to keep shooting up. I'm just going to keep doing this. I know it can kill me, but who cares? So they have given up hope. They are despairing. These are the deaths of despair that we hear about with people who don't have a job, don't have a future, whose families are rejecting them, whose families have basically banned them or shamed them. And we all have taken care of patients like that, who are just not responding to our best love, our best help, our best medications, our best treatment programs. And they say after a while, thank you, but no thank you, fuck it. Next, please. So we have to ask ourselves as caregivers, when is enough enough? When have we done what we can do? Are adding restrictions going to be useful? Is putting an involuntary hold on this person or committing them going to be useful? Or is it just going to be more torture? What are we doing to them that's going to really be helpful? Are any of the things that we've tried over and over again useful, or are they futile? People aren't futile, treatments are futile if they don't work. So after you've given the same treatment 10 times and it hasn't worked any time, or the results last for a month, and then the patient goes right back to what they were doing, does it pay to keep doing it over and over again? And then the question is, without these conventional treatments, how can we care for these patients? Next, please. And that's what we get into palliative care. So what is palliative care? Palliative care is not preparing people to die. Palliative care is saying, how can we help you live better? How can we relieve your suffering? How can we make you more comfortable? And the cornerstone of palliative care is what's called the goals of care conversation, which is treating somebody with respect and saying, well, what do you want? Here's what we can do. What is it that you want in your care, in the time remaining to you? So a lot of my patients say, I don't want to be hospitalized involuntarily. I don't want you to do something that I know isn't going to work for me. What I want is leave me alone and I'll do how I do. I don't want to be forced to increase my weight unrealistically to ideal body weight when I know that I can't keep it there. I can live at 80% body weight. I've done it for years. I can't get to 100% of what you want. And if you leave me alone, I'll be okay. And with that program, I've had patients who've lived for 5, 6, 7, 8, 10 years more without being coerced, where they don't have to fight their doctors, where they don't have to fight their caregivers, and you treat them with respect and you treat them with dignity, and you say, okay, let's set some basement boundaries. At what point do you think it would be reasonable to hospitalize you if you want your life saved? So let's set a certain weight, let's set some behaviors, and we'll know at that point we'll do something, we'll intervene. In the meantime, you come back to the emergency room or to the doctor's office if they're willing to keep rehydrating you because you're binging, purging, or getting dehydrated or something like that. We'll get you back into electrolyte balance. We'll put on 1 or 2 pounds and send you out again if that's really what you want. That's palliative care. How can I make you more comfortable? Can I take care of your depression, your OCD, your suffering? You want medication? Fine. You don't want it? We won't force it on you. We won't force it on you. Anytime a new treatment comes up that I think might be interesting, might be useful, I'm going to let you know about it. I'm going to offer you whatever treatments there are. Psilocybin work? I don't know. Let's see if you qualify. Ketamine work? I don't know. Let's see if you qualify. Does TMS work? I don't know. Let's see if you qualify. So all of these things, would you like to be in a support group? Would you like a peer counselor who can maybe walk with you as you're walking? Do you want those kind of things? That's palliative care. And the palliative care offers social service, therapy if you want it, the kind of therapy that you want, spiritual care if you want it. It's a bouquet of things that might help you achieve dignity and know that we're not treating you in a stigmatizing, denigrating way. We're not treating you like a sick little puppy when we know better than you do. We're saying, it's your life. How can we help you live it better? That's what palliative care is. Hospice care is different. Hospice care is something that you get when you are within 6 months of death by clinical judgment. Everybody says this person isn't going to live more than a couple of months. You qualify for hospice care under Medicare. I have had a patient with severe eating disorders who had been struggling for 20 years, who we put on palliative care, who did much, much better. She got a college degree under palliative care. She then started to deteriorate and went to hospice care and then started to do much, much better and was in hospice care for 3 or 4 months and then didn't need it anymore because she touched into something that helped her to get better. The miracle is she got married and is going to have a baby. This is in her mid-late 30s after years of struggling and struggling and struggling. She's not entirely free, but she did it on her own after the eating disorder police stopped mistreating her and beating her up all the time. One patient like that. Other patients who have benefited hugely from palliative care. One patient I'm taking care of now who's been in palliative care for 5, 6 years, who's managing to live a life which she would not have lived had she been repeatedly, as she had been for 30 years, coerced by treating eating disorder programs. Next, please. So, a good life is something that we all want, and according to this statement, we all deserve. What can we do to get it? Next, please. What do patients with psychiatric disorders need at the end of life? They need proactive physical health care to get early diagnosis. They need care that maximize that their providers, their medical providers, and their psychiatric providers are going to be talking with each other. And if they have long-term providers who they like, maybe being able to stay in touch with them. Um, Discussing long-term planning if they are able to think about that. What do I want at the end of life? How would I like to die? Where would I like to die? Would I like to be cremated or buried? All of these really very practical kinds of issues. I would like my own desires to be listened to and honored. So I'm treated with dignity and respect, even though I have a psychiatric disorder, even though I'm bipolar, even though I'm schizophrenic. I know I'm dying. I know I would like to die this way if at all possible. Next, please. I'd like to maybe make peace with my family, to have them around if possible. I'd like my family's needs to be respected. And I would like everybody to be working together, kumbaya. My medical team, my family, and my psychiatric and medical teams, everybody's going to be in this game together. Next, please. We realize that a lot of staff, you all, if you are going to get into this kind of thing, would need to have some training in what palliative care really is about, how to do that, what it means to care for families and patients at their end of life, how to talk with them about it, how to have these discussions, how to feel comfortable in your own skin about death and dying, about what you want, how you would like to die, how would you like your family to die, and bringing in anybody who can help. So if they're friends, families, volunteers, spiritual workers, let's get them in on the game. Next, please. Going forward, what will make this work are co-located medical services and psychiatric services, supportive housing, which everybody knows, and as a field, more research into what we mean by slow suicide, how to understand that, how to better take care of patients who are on these death trajectories, which we've all seen and recognized, but aren't very good at intervening with at this point. And I haven't even talked about, leave it for the discussion, the issue of medical aid in dying for patients who have serious mental disorders. There's a whole world out there. It's just starting in the United States. We're just starting to think about it in the United States. Is there a role ever for medical aid in dying for people who are suffering from psychiatric disorders? With that, I will bid you a great day, and let's get into some discussion. Next slide is thanks for listening, and my email if you need to get in touch with me. Take care. Okay, Kim, it's back to you.
Amazing and wonderful. Thank you so much for that presentation. And I know, so anybody who has questions, who wants to ask questions, you can either put those in the Q&A box or in the chat. I've written down about 10 of my own, so so if nobody else wants that, I would like to start with the very last thing you talked about, medical aid in dying. And
Okay.
do you have any thoughts about that? Whether or not there is a need or a role for it in psychiatry
Yeah,
generally, and then with eating disorders more
sure.
specifically.
Let me just say I have not taken part in any medical aid in dying myself. I have a colleague who has with patients with anorexia nervosa that I'll talk about. The first thing is, I think medical aid in dying is a good thing for people in general to have available. One of my cousins, who is a clinical psychologist, who was working with Commonweal, a kind of a program in Northern California that helped people who are dying of cancer. Herself, at one point, she developed uterine cancer. And she said, "Oh my God, I am now one of my patients. What do I do?" And she arranged a dignified death that actually was included in an HBO documentary on death and dying, where her family was around, everybody was smoking grass, everybody was happy. Uh, she felt great about it. Her kids were there, her husband was there. And she decided at a certain point, I've had enough pain and suffering. And she was on tons of narcotics for her pain at that point and asked for medical aid in dying and received it. And the family participated, and it was like a spiritual experience. I mean, everybody's going to die. She knew she was going to die. She incorporated her loved ones in this natural process. I wrote a paper and I said, it's going to become the kind of thing where you're going to have a caterer at your death and dying party at the end of life. There are only 10 states where it's available, and in none of the United States yet is it said that somebody with a psychiatric disorder, just on the basis of a psychiatric disorder, can request medical aid in dying. So now the paper on terminal anorexia nervosa described 3 patients in California. I don't no longer have a California license. I did when I was at UCLA for many years. Obviously, I just have my Colorado license. One of my colleagues, who's an internist, has a California and a Colorado license, and was asked by patients if she could help them with medical aid in dying. They were dying of anorexia nervosa. They had lots of care. They had given up on conventional care. They didn't want it anymore, and they knew that locked into their anorexic behaviors, they were going to die. They had palliative care physicians who were California-based physicians who were licensed, who didn't feel comfortable about this. And one of the patients, who was a master's in social work and the director of research in the Department of Pediatrics at Stanford, this is a lady with a publication list like this, smart, herself had been struggling with anorexia nervosa for 20 years and said, I've had it, I'm going to do this. Would you help me with my medical aid in dying? Her father is a professor of anesthesiology, retired just now. Her sister is a pediatrician specialist in palliative care medicine. This was a very informed, intelligent family who came around to agree with Alyssa's desire about how she wanted to die. Alyssa, at this point, had severe malnutrition. She had medical complications. And it was having medical complications, which you have when you're dying of anorexia nervosa or of alcoholism, that was the medical condition that made it justifiable to provide medical aid in dying if she wanted it. She wanted it. My colleague wrote the prescription for the medications. And Alyssa, our co-author on this paper on terminal anorexia nervosa, died a day before she planned to take the medication. She died of anorexia nervosa, from the medical complications of anorexia nervosa. She was miserable and suffering when she died. She tried to keep it together. If you read the paper on terminal anorexia nervosa, you will read her own description of what she went through, her lived experience,
Right.
her justification for why she wanted medical aid in dying. Of the 3 people in that paper, I think maybe one of them actually took the medication. Maybe. And was also as ill and as miserable and suffering and medically complicated and treatment difficult to treat had gone to treatment over and over and over and over and over and over again, and it never worked. And finally said, I've had it with the family's agreement around trying to give him a dignified death. So again, these three people said, I don't want to die of suicide, which would have shamed me and my family. I don't want to die in some miserable hovel. I want everybody around to understand what I'm going through. I am dying. Can you be with me? Can you give me medical care? Can you hold my hand? Can you be a midwife to my death? Can I die with some dignity, please? That's what this was about. So in the rare, rare cases, rare, I mean, I've treated scores of patients with severe and enduring anorexia nervosa. I've had on my own, 4 of my patients have died from anorexia nervosa over the years that I'm aware of, tried to be with them to the end. This is a handful of patients. In the 20 or 30 years that medical aid in dying has been available to people in Europe, only maybe 20 people are reported who have asked for it with anorexia nervosa. And most of them have had other psychiatric comorbidities like borderline personality disorder. So it's not a huge number of people. If somebody comes to that place, if they are decisionally capable, and these people were all seen and evaluated for decisional capacity and had clear judgment. They knew what they were doing. They knew what they were asking for. There's no reason in my mind to deny the same kind of care that somebody with cancer would be getting. If you're miserable, suffering, medically compromised, dying of something, and you're saying, listen, I'd rather not suffer another 2 weeks, and it's legal in your state, I think it's justified. That's my own opinion on it. I think veterinarians are much more compassionate than physicians. People know when it's time to take their dog to a veterinarian to be put down because they're suffering or they have an untreatable illness. We're not as compassionate. Isn't that weird?
Yeah.
Think about it. I mean, what are we holding on to? We're going to die. At some point, you're going to die. Everybody you love is going to die. How do you want to die? Do you have any say in it? And that's what this whole discussion is about. Let's make our own deaths better. Let's make our patients' deaths better and more dignified if we can legally.
Right. So I think, sort of related to that, this patient that you described that was in hospice and now is,
Well,
having a baby, right? You said something happened for her or in her or to her in
I
hospice.
think here's a
What was
woman
it?
who went into hospice not because she wanted to die, but she was suffering.
Right,
And I think what happened is with the hospice care alleviated the suffering. So she was able to better tap into her own resilience with therapy. I mean, she continued to be treated. I continued to see her. She had a very good therapist, and she got better. But nobody was holding a hammer over her saying, this is what you have to weigh. So
right,
she didn't have to fight the system. That's what worked for her. What the terminal anorexia nervosa patients have done at some point is they have said, I've had it. I can't fight this anymore. It's bigger than I am. I think I am going to die. She never said that. She just said, I don't want to suffer so much. She was put into hospice when it looked like she was going to die because her weight was falling and she was malnourished and so forth. She didn't want to die. So when the
right.
suffering was reduced, she got better. I mean, she had that in her. She had some spunk and life force. And I
Right.
think
Well, I
people
think
realize
part
this.
part of the, part of what people in psychiatry or other areas of medicine, palliative care doctors might say, well, how can you determine somebody whose brain is malnourished has
Yeah.
competence, right?
Well, I
So,
mean, so part of that is that there are competency exams,
right,
and you do them, and if somebody says can give you a decent explanation of what their situation is, what their if this choice is consistent with their values forever, uh, it's pardon me the expression, it's a no-brainer. I mean, people with anorexia nervosa can be competent. I mean, just because you have a diagnosis of anorexia nervosa, even if you're malnourished, doesn't mean that you lack all decisional capacity, that you can't make decisions for yourself, especially if they're consistent with your life.
right,
When you think about psychiatric patients, some patients have the angel of death sitting on their shoulder from the minute you meet them,
correct.
right? So, where did that angel of death come from, and what is that about? It's about suicide runs in my family. It's about life has never been that pleasurable to me ever anyway. It's about I'm not attached to living. There are some people, regardless of what's going on with them, who say, I want to live, I want to live, I want to live. And that's a temperamental characteristic, very deep personality character that we may or may not ever shift in intensive psychotherapies. If somebody has an angel of death on their shoulder and you're their therapist, you know that you're at risk of having a patient die under your care at some point. Either
Right,
they'll tell you or they won't tell you. Either they'll write a note or they won't write a note. Either
right,
they'll give you warning or they won't give you warning. But that death is with them all the time.
for sure.
And it's like a dark cloud that's following them around, and you know it's there, and you say, well, let's I mean, if you're doing therapy, you're going to say, let's put it on the table, let's examine it, let's see where it comes from, let's see if we can alter it, let's see if we can change your thoughts, your emotions, whatever, in association with your angel of death. But working with somebody
And
who's a
let's talk to
chronically,
your family about it too, right?
yeah,
Like, let's
and
involve your,
involve the family, you get everybody in. I mean, working with a chronically suicidal patient has its own whole set of psychological issues, countertransference issues. I've written a paper about that. If anybody want to find it, I'll be happy to send you a copy
yeah,
on dealing with wrestling with the angel of death, it's called.
okay.
So
The
a lot of that
titles of your
wrestling,
papers are
excuse me?
the titles of your papers are just so creative and,
Well,
wonderful.
I was trained by my um, writer, director, producer, patients at UCLA who are all in the film business. And they said, you have to grab somebody with the title.
Yes, you do a great job of that.
It's a trailer. You have 2 minutes to tell me what this is about. If you can't make the case, forget it. So you have to do it with the title.
Right, right, right. So here's a question so first there was a comment from Dr. Brewerton. Thank you for a brilliant and clear
Kim, how are you
presentation.
doing? Good to see.
And then a question from Lee Millert. This was excellent. It strikes me that for trauma patients, some of the medical issues may also be the outcome of their trauma history, as was shown in the ACEs study.
Yes,
Um,
absolutely.
though, of course, their psych issues may also contribute. Does that seem likely
No,
to you?
absolutely. I mean, ACEs show that you really can't separate biology from psychology. I mean, we're developmentally biopsychosocial characters. And the earlier you have trauma, the more at risk your whole medical development will be. So that certainly contributes. And that goes along as another risk factor as to why people with psychiatric disorders have greater vulnerability for early death. I
Yeah.
mean, if you've been traumatized in early life, you're going to be much more vulnerable to all of the chronic medical conditions we know will put you at risk for earlier death.
Right. Um, Here's another one of my 9 questions. What is the difference in your mind between palliative care and harm reduction?
They are compatible. There are Venn diagrams. I mean, harm reduction is to give you some skills to cut back on your self-harming, whatever it is, drinking, purging, cutting, so forth. Palliative care is to reduce your pain and suffering. So if reducing your pain and suffering allows you to reduce your harmful behaviors, all well and good. It's all kind of, they overlap. I think with harm reduction, you also use more DBT specific kind of training to get on top. I don't want to cut. I don't want to cut. I'll do this and so forth. That palliative care could encompass, but doesn't necessarily focus on or privilege.
Right,
But certainly they're compatible, and you do the two of them together.
right. And I think, so we have a harm reduction virtual IOP, and part of the pushback, I mean, there's all sorts of pushback from, I think, people in the community, patients, patients with, who have recovered, right? But internally for therapists,
What are they pushing back on?
oh, you're giving them the easy way out, you're enabling, you're
Oh,
causing harm to them.
great. I have another paper with the title of course, harm reduction is good. Who wouldn't want to reduce harm?
Right.
And that's uh, it's ridiculous. It's a non-discussion.
Yeah.
It's like those other people that you were talking about who said nobody should ever get made.
Right.
It,
Yeah.
I mean, what you're doing is you're taking care of. I said the real issue is how would you take care of this person with these specific contextual issues
Right.
and this specific psychological profile and makeup and direction right now? How would you do it?
Right. Well, and I think for the therapists and psychiatrists, there's internal resistance because, how am I harming this? They start to think, am I harming this patient by not forcing them to do a higher level of care, forcing them. They don't
Yes,
necessarily say
it's
forcing them.
and in fact, it's the force that is counterproductive.
That is
In
the
my
harm.
experience, it's a harm.
Right.
Forcing is a harm.
Right. Right.
Forcing traumatizes.
And am I giving
Forcing,
myself as a therapist
no,
an easy way out because I'm no longer
an
like
easy
trying
way
to.
out because if you reduce harms, the patient may get better.
Right.
If you're not making them more miserable by your ineffective treatment, if you're
Right.
not inducing suffering
Right.
by forcing them, you're
Well,
doing them the favor of allowing them to tap into their own resilience and not have to fight a two-front war. They don't have to fight you and their disease. They can just fight their disease.
so, and I think there are three sort of, you know, primary reasons for therapists that this is so wrought with emotionality and resistance. One would be like, we're not very good at saying our treatment is ineffective and there's so much that we don't know. And that our
Well,
treatment might even be harming you.
yes. Well, maybe we need to train our therapists in groups and to be more comfortable with that. It's
Yeah.
just like people who are uncomfortable with death.
Well,
I don't
right.
want to
I think
think
that's
about
the
it. I
other
don't want to deal
reason.
with it. Yeah.
What if the patient dies
So the
while they're
patient's
my
going to
patient?
die.
Right? Well,
Right.
some patients die.
Right.
It's the
Sure.
business that we're in.
Exactly. Kubler-Ross, Elizabeth Kubler-Ross, who's one of the early people in the death and dying business, said caretakers are very good in saying, I don't want the patient to die on my watch. And the reason is that they thought that they would be blamed or
Right.
shamed or stigmatized or embarrassed. I think if you don't have patients who die under your watch, you're not taking care of sick enough patients.
Right. Right.
Everybody's going to
Well, I think
die.
that's the other reason, right? Like I'm going to get sued
Yeah,
or I'm going to be stigmatized by my
sure.
colleagues.
I think we have to deal with those countertransference issues to help our clinicians become better clinicians.
Right.
Those are biases that are actually anti-therapeutic biases in a way. It prevents you from taking care of this patient, giving her what she needs now.
Uh, Tim, Dr. Brewerton says one of the most powerful books that influenced my practice is Existential Psychotherapy by Yalom
Absolutely. Irving
that
Yalom,
he read just a couple years ago during his
yeah,
residency.
that's right. It's a book that I've been recommending to my residents from year one. Uh, and it's beautiful. And I think we all have to think existentially.
Well, I think that's, part of why, um, so usually we have a bunch more questions after these presentations. And
Uh,
today we've had one really, a lot of some comments, one question, because I don't think people like looking at, you know,
well, and
the questions
mortality,
that you asked about how would you like to die? And what would you like when I think of a patient that I treated for many, many, many years who died alone and in a hotel room, right? And I think
mhm,
about what would I have wanted for her at that point after battling, eating disorder, substance addiction, trauma, chronic suicidality for 30 years,
right.
you know. It's not that,
Mhm.
you know. And I don't think, and we had been talking with her family for years about like there's a high likelihood that your daughter is going to die
Sure,
from this,
right.
right? But
And
still there was that sort of like pull, I would say, as a treatment community, um, to like, well, isn't there, what if this time's different, right? Which is
yeah,
insanity after, 10,
sure,
10 times, maybe if
right.
I say it this way, or maybe if we add
Sure.
this, adjunct medication, right?
As opposed to accepting the fact that there are lethal diseases, there are lethal psychiatric diseases. You do what you can, you do the best you can. You never don't offer the patient treatment. So you're
Right,
always saying, I'm there, we can do this, we can try this, but force feeding adds to trauma and suffering. We,
right,
whether we want to or not, iatrogenic, it's an iatrogenic um, harm in some
right.
way.
Well, and, you know, and if, when you think about and look at higher levels of care, particularly in eating disorder treatment, people are kicked out all the time for
Right.
failing treatment versus our treatment is ineffective. What could
That's
we do
right.
differently? And, if you
That's
can't
right.
complete, X, Y, or Z, like
Yeah,
amount of food in this meal 6 times a day,
sure.
how the conversation is so rarely what can we do differently.
That's
It's
right.
more so focused on this patient just isn't ready yet, or this patient is being willful or resistant,
Yeah, it's always blaming the patient, isn't it?
which does harm.
Exactly. So you have to think about it like chemotherapy. Some chemotherapy treatments are so toxic that
Yeah,
they do more harm than good. And then
yeah,
you stop and you say, what else do we have, if anything? And that's what eating disorders treatment is like too. What do we have to offer that's not going to make you miserable, suffer, and worse than you were?
right,
Because now you feel diminished, stigmatized, branded in some way.
Right.
And that means that we can't help you.
Right.
We can always help somebody by just being there
Right.
and having what
With
I call
compassion.
compassionate witnessing.
Right.
I'll be with you. I'll watch what you're going through. You're not going to be alone.
I'll actually listen to you
Yeah,
and honor your voice and your
yeah.
choice and your wishes.
And if you need it, I'll hold your hand.
Right.
I'll be with you.
You would touch a patient, Dr. Yager?
Absolutely. Absolutely. Even hug a patient.
Me too.
Yeah. All
All
right.
right. Well, we are at the end of our time today. Again, Tammy Gazer will send a link to anybody who came today for the CE. Share with your colleagues and trainees. This will be available recorded in about a week or 2 weeks, and it'll be available for the next year. Thank you
Terrific.
again, Dr. Yager.
Pleasure. Have a great day, everybody. Thanks for listening.